exclusion criteria for getting into a study in order to study something is to not be pregnant. And so that because drug manufacturers are very concerned about that. So most of the medications that we have, we actually don't have many studies surrounding it, and what we know is mostly from anecdotal reports, but there are some studies that exist. If you go to PubMed, you'll be able to find them. PubMed, I think it's .com. You can just do a search for PubMed. All the studies right then and there are there on the internet for you. If you don't have access to that, if you can't find it, I'm not sure, I don't think they charge a fee. But if they do, you go to Google Scholar, and they have everything as well too. You may not be able to read.
PubMed is private, and you have to have an account.
But you can go to Google Scholar, they have the same studies, and you may not be able to read the entire articles, but you can read the initial blurb, which is called an abstract, which tells you the study in a paragraph, the study and the results of the study, and the conclusions of the study. So
thank you.
Yeah, but to let you know, this is an issue that's near and dear to my heart. I think this is an area in DMH which we're still a little bit backward on. I think we're at least 5 to 10 years behind the curve compared to most other places in California, especially most managed care agencies. I'm bringing on board, which I'm very proud of, a psychiatrist who specializes, probably the #1 psychiatrist in this field, specializes in women's health and reproductive medicine. She's going to help teach all the rest of us how to do her job.
Call me if you need some information.
I will. But just to let you know, most of the medications are reasonably safe in pregnancy, even if there are small amounts in the breast milk. That most of them are reasonably safe for the children. But if you're on medication which is not FDA approved, doesn't have enough studies, there are other medications that we can switch to that are proven time and time again, like Psychiatry, to be safe in this area. There are very few medications that are really dangerous in pregnancy. And when we talk about the medications where we don't have wonderful data, but we have good experience, it's important to know that you have to look at all of the risks and all of the benefits. And a lot of times it's really important to stay mentally stable and take the little bit of risk by the medications you're on, because that's going to be better in the long run for both you and for your child. So I think it's important for us to remember that, and I think it's important for us, when patients come to us to our clinic and see psychiatrists, that this is one of the first questions we ask. Not just, are you pregnant, but do you intend on having kids in the future? And because we need to plan for the long run and really think about the whole lifespan. And maybe you're not going to have kids for 5 years, but it's important for us to start planning that treatment regimen for that time period, so that everything can be safe and we can look at all the risks and benefits, and the patient is in the know. So that's very important. Yes,
Next question over here.
Next question over here. Yeah.
Hi. There can be many obstacles getting medications to our loved ones, but going onto the street and coming into the home to provide medication is a great idea. My situation now is that my son has generalized anxiety disorder and schizophrenia. He's paranoid. No one can get near the house. He doesn't leave, and if anybody from DMH shows up, he's hiding. I feel that we need to have specially trained people in the field who know how to cross the bridge and reach out to someone with these particular types of symptoms. And that would be very helpful.
I hear you, and it's imperative, and that's the only way any kind of a system will work. It's similar to what I was saying about the psychiatrists on the beat. Not all psychiatrists are made for this, being on the street and talking to people where they live and breathe. Not all social workers are made for that. Not all psychologists are made for that. It's important that we select the right individuals who can really talk, not as shrinks and social workers, but as people, person to person, and really open up and discuss this. And I think that I'm very sensitive to that. So as far as I'm concerned, I'm not going to accept anybody who is wrong for those positions for street psychiatry. I'd rather have a position unfilled than have someone who can't speak to people.
I think that needs to apply to FSP as well, because I have an issue with FSP on that particular matter.
Yeah.
I think all of DMH realizes that the implementation of FSP has not really worked as it was envisioned, which is often the case for large government organizations. The implementation is the problem, not the idea. And so we actually paid a private company, Mercer, our consultants, to really look at FSP and help us devise a system that really actually functions the way it was intended, and which means that they really need to be available 24/7, and for so many reasons.
I was part of that study. When will the results of that study be available?
They're just coming out now. So
That was an UCLA study, I think?
it's Mercer, yeah. There is a UCLA study as well too. So we're looking at this from multiple directions. And the Mercer report is one that involves all three health departments in the agency. So DMH, Department of Health Services, which does all the inpatient work and all the regular primary care work, and Department of Public Health, which actually is doing the substance use treatment. So all three are going to be involved in the solution. It's still in draft form, and they're asking for feedback from us, but we're almost there. And UCLA, I think they're very close partners, and they will for sure help us devise a system where they participate as well too out there in the field. So that's a demand, but we're really going to work on this. I cannot tolerate remember, I worked in emergency rooms for many a year, and I used to call FSP, and all I did was just go ahead and admit the patient, and we'll see him next week when we get back from vacation. Yeah, I know. So we as clinicians have that same experience. So I know where you stand there, and we're going to fix that. We're going to fix that.
Question here, actually, folks, questions in the audience, if you have something to say. Line.
Hi. Thank you so much for coming. SB 82 is very close to my heart as well. Has the county come up with the rollout plan that you can discuss with us as far as when this will be rolling out and where and how many mobile units you have, and how will you tell the constituents that it's now available? How will they know where to go? Has that been determined yet?
Yeah, it's a good question, and I can't give you too many specifics because we're really too early on in the process. So this is growing, maturing as we speak, and we're really kind of at the initial stages. By the way, stakeholder support is going to be crucial to the implementation. There's so many things that we've tried to implement that didn't work too well because we didn't, we passed
It's difficult.
past regimes and DMH didn't really necessarily involve stakeholders in a robust manner. So, so therefore doing that is going to take a really long time. We want to make sure we do it right and carefully.
Well, I'm just glad you're moving on it.
Yeah.
Yeah, I'm on the State Mental Health Commission, and so I'm really excited about this.
Yeah.
And I will be following.
So
Thank you.
Thank you very much.
Question over here? Dr.
Good afternoon. My loved one is having a second episode within about 2 years. First time he was on in Vegas, the Staynet, the injectable, and he started going to school, working, did pretty well, except he gained about 70 pounds in 9 months. And so now then he decided to stop taking the meds, and then now symptoms came back, but they're different. He has a lot of marijuana addiction. And this time they're giving him psychiatric. So he's not reading the information about the drugs, but I am, and a part that concerns me about both of them is just the tremendous weight gain that can be expected, which of course can lead to diabetes. So I don't know if you have any particular thoughts, comparing one drug to the other, like Prexit and Vega Sustaina, and is there any kind of medication that helps with marijuana addiction? Thank you.
Yeah, I don't have much information about medications for marijuana addiction. I just don't. I don't want to pretend like I do. I will say, the next meeting we have one of my colleagues who's a specialist in that come up here. But I will say that these medications, these new generation antipsychotics, everybody thought they were the God's gift. And then they started realizing how many side effects were attached to them. And it's a very real problem, and it does make it difficult for patients to keep the weight off a lot of the times. It's a give and take. There are a lot of medications, and there are new medications coming out all the time, including injectables, that don't have as much weight gain, as many side effects. Metabolic syndrome is very, very low in frequency for these medications, and we have them available. One doesn't necessarily work for everybody, and it has to really be, choosing medications kind of has to be a creative approach that involves both the psychiatrist and the patient to come up with a fine-tune that, because nothing works for everybody. So there are medications out there. Even Zyprexa is a wonderful medication if we prepare for the side effects right off the bat and help educate the patient and help provide programs in order to prevent that kind of stuff from happening. There was a study that a psychopharmacologist mentor of mine conducted that all they did in the study, they gave patients these medications. One group, they did nothing. The other group, at every appointment, they just weighed the patient. That's it, and told the patient what the weight is. Those patients didn't gain, were between 5 and 10 pounds underneath whatever all the rest of the patients. So something as simple as that, just weighing the patient, helping track the weight, it can reduce the burden of this. And that goes to show you, if we do more stuff, that we can actually really, really have, make a definitive change. And, yeah.
Names of maybe a couple of the low metabolic meds?
Well, we have Aristata as well too, which is a good one that's now on the formulary. Latuda has very, that's not, doesn't have an injectable version, but it's a very good medication which is on our formulary, and it really has very few side effects overall. That's why people use it for just about everything these days. Unfortunately, it's one of our most expensive medications, but so be it. It's a good medication, and there are medications in testing right now. So the sun is rising on this. It's not setting. So I think there's really a lot of opportunities. And all the medications that we have now, we have a whole slew of medications that are oral. Abilify, we have Risperdal, we have Zyprexa. We have some of the older generation medications which actually don't have much metabolic syndrome. Some patients do really well on those too, and we shouldn't forget those. There's a lot of opportunity, and I think we're just at the beginning of the third generation of medications, which really will be game changers. We won't have to worry about this at all. But the answer to the question is, got to keep trying. One medication can cause someone to have weight gain and not do it at all to the next patient. So it's trial, to a small degree, trial and error, but there is a way to do it that involves patients, and it needs to involve a total program to help patients resist the metabolic syndrome that occurs with these medications, which includes primary care work, and we want to bring primary care to DMH as well too. So that's a big thing for me. What I want to do is bring substance use treatment into DMH and also bring primary care management, because my opinion is, and I've seen this at the VA, sometimes we only have one chance to get a patient into treatment. Someone may, after weeks, come in after deliberating for so long, is this the right thing to do? And we can make sure we cover all bases, because a lot of times I consider us the primary care physicians for a lot of our patient populations. So,
Okay, we're ready for another question.
yep, sorry.
Well, thank you, Doctor. I'm asking about my sister who's on Abilify, Clozaril, Ativan, Zoloft. She's 65. And she's cut down a little and done well. But my question is, in the past, she's had 2 bad reactions to Risperdal and possibly 3. And I'm afraid one time, you know, that she might end up in an ER with her inappropriate behavior, and they'll say, well, we'll give her some Risperdal. And it kept her awake for days and severe agitation and some kind of chip or something where you just wouldn't get that.
Yeah, that's an interesting idea, Chip. We have the technology right now. It's interesting. I'll let you know that there was a study, or they tried to start a study once with 100 patients with Alzheimer's disease and their caretakers. They would chip both. And the caretakers were all for it, but patients' rights groups resisted that and didn't allow it to go on. They thought it was inhumane. But knowing what I know, that's a reasonable mechanism in order to keep patients safe, just like the wristband. What we don't want to see happen is patients with signs on their back saying, "Please return me to the 3 E's, bed free." I've seen that, and there are a lot safer ways to do it, a lot more humane ways to do it. It's an interesting idea, but the greater problem is, even with, it's going to take a while for something like that to happen. But the greater problem is a lack of communication between the different departments of the health agency, and we're working on trying to improve that, where we can read each other's records in a robust manner, and that will solve a lot of those problems. Fortunately, the side effects follow patients, not the side effects, the allergies follow patients from hospital to hospital. We generally have records of what will, and when bad reactions to medications, they may not be allergies, but oftentimes they're listed as allergies. So, but I understand why you're fearful. I don't have an answer that will save everybody at this point. It's a difficult situation, and we've got to find a way to do that. Plus, if we don't do that, and even younger patients, if they come in and we inject them with something that, or give them a pill of something that they've had a bad reaction, the trust is out the window at that point. Right? So there's other reasons to do that too. I wish I had a better answer for you.
Okay, we have another question over here.
Hi, my adult daughter has been diagnosed with borderline personality disorder, major depressive disorder, and anxiety. She's on Seroquel, Effexor, Ativan. Are those the drugs that you would recommend?
It could be great. There's not. I don't see any major red flags with that. I have to know the situation and the patient. And probably in my mind, I never like to give an opinion until I've reviewed the case and actually seen the patient face to face.
Also, earlier you were talking about facilities that treat the patients as a whole instead of breaking them up by diagnosis.
Yeah.
Can you recommend a facility that will treat? I can't get her into a facility because of those diagnoses and alcohol use. It's either I get a no everywhere I go. So, are there facilities that DMH can recommend looking towards?
There are a lot of ways that we're trying to combat this, and one of the ways is we're developing restorative care villages, which will be campuses which have all kinds of treatment: primary care, substance use disorder treatment, and mental health treatment, all in one spot. and including housing, including crisis residential, every level of care, subacute facility, every level of care, and we're trying to place them at where we have all the major county hospitals. So, what's available now? There is a Medi-Cal waiver that gives substance use disorder treatment centers the ability to actually employ psychiatrists and give mental health treatment as well. That's the first step. It's limited, and it doesn't really go both ways at this point in time, unfortunately. But the goal is to develop these facilities, and what we're doing is we are reevaluating our contracts with all our private entities, inpatient and subacute entities, and we're going to build things like that into the contracts so that they can get robust treatment. Dr. Partita is going to be a big proponent of that, and all of us discipline chiefs are participating right now. I'm running it, but all of us are participating in really looking at network adequacy and really trying to develop contracts which support the needs of our patients in demand. So there isn't all of that. It's still kind of fractionated at this point in time. I can't give you any great recommendations of centers that do everything. They still kind of do their specialty, but they're coming shortly, hopefully within the next year. But you know, the county hospitals are still pretty good at treating them. She has insurance? Yeah. Well, I'll tell you what. Give me your contact information, and I'm going to research it, and I will give you. I'll talk to my people and get you the nitty-gritty details.
Very good, thank you. We have another one over here.
Okay, this is sort of a segue to a previous question. First of all, are you also overseeing the mental health care of the people in LA County and then Central?
We're not. Well, we are, but we're not. We're not that we don't employ the docs who are in the jails, but we do all the work when they get out of the jails. So right now, believe it or not, the county is really kind of forward-thinking and realizing that a lot of mentally ill are inappropriately in jails and prisons. So there's a diversion program that makes the early release. And also at work, I'm trying to institute a vigorous program, robust program, where we can divert from the jails right from the start so they don't have to go there in the first place. We are providing immense amounts of treatment to this population. In fact, over 80% of our new clients, believe it or not, are patients who are incarcerated.
Well, I'm glad to hear that, because there's a dangerous lack of continuity of care.
There is.
Patients sees many different doctors, and it could be very dangerous.
I agree. The lack of continuity of care is one of our biggest problems. It's something that, unfortunately, there's a political aspect to it too, and I don't know why that is, but they make it real difficult sometimes for us to talk with each other. But I agree, it's important. And we have big ideas. The Department of Mental Health really is looking to take over all of mental health in Los Angeles County, including putting people in primary care clinics, including people taking back the physicians who are working in the jails and prisons. And it's very important to us, and in that way we have continuity of care. By the way, we're also trying to, we're supporting training programs for psychiatrists, and eventually we want to bring those training programs into the Department of Mental Health, because we believe that we can educate on public health better than anybody. So we want to develop the clinicians of the future. So that's what we're doing. We have big ideas, and I think we can get there. But you're right. This is a weakness, the continuity of care.
Thank you very much.
Yeah.
Okay.
By the way, just before, I wanted to say to the woman who has a family member who is aging and a problem with Risperdal, we have a lot of great FSP teams. Most of them are fantastic, and they do a good job. And that particular case and many others may be appropriate appropriate for FSP, so there can be a little tighter control over what happens and they know what's going on. We also have in DMH Genesis program, which that's what they do. They specialize in care of older adults, and they train as well too. So they are the Center of Excellence in Los Angeles County for that. So there are different mechanisms to do that. I just wanted to say that give us a call, and we'll try to come up with a treatment program that keeps your family member safe. Yes, sir.
Yes, I was just a little bit troubled by a couple of things that Dr. Kakita said during his keynote speech, and I know you can't speak to his opinions, but I was hoping you could give me DMH's viewpoints. He said that medications are good for short-term use, which implies that they're not supposed to be used long-term, or that he doesn't think that they should. And he also said that recovery is possible, and I just want a clarification on that. Is it DMH's opinion that recovery is possible for all patients?
Yes, absolutely. And we firmly believe that. And one of my team, one of the discipline chiefs, is proof of that. These illnesses that are called the SMI population, severely mentally ill, schizophrenia, bipolar, we just don't believe in that. We believe that if you do the right things, we have the treatments in place that can actually improve life and not keep people in a sick role for the rest of their lives. Everybody can have meaningful lives, and we honestly believe that, and this is what we're moving towards in DMH and all of our contracting facilities. As I said before, we're changing our contracts to support the multidisciplinary team approach and support recovery. And we won't settle for second best on that. As far as medications are short term, I don't know if that's exactly what he meant, but for sure he believes, and so do I, that medications are a tool, but there are a lot of other medications aren't the be all end all. Without having the other tools that are the same tools that you and I would use if I wanted to go get a job training, and if I wanted to find a different place to live, I can get that too. I go to someone and get support. All of this stuff is necessary, including psychotherapy and counseling, to help someone recover. Medications alone, I agree that they don't make everybody recover. I think you need coordinated, comprehensive treatment plan for every single patient. So I, as a psychiatrist, do not believe in medications only either. Fortunately, a lot of my psychiatrists, they actually do psychotherapy as well too, and counseling with all their patients. But we need it to be more, we need the multidisciplinary approach, not just lip service, but actually a robust treatment plan. So, and I'm not sure I agree with the statement that medications are only short term. No, the medications are very, very helpful and are a game changer for a lot of our patients. And they will oftentimes be a lifelong tool to help people get through recovery. And recovery is not just a 10-year process, it's a lifetime process. Same for us, same for those who don't suffer from mental illness. It's a lifelong process of maturation and improvement and really kind of finding structure for goals together.
Very good, thank you. We have another question.
Yes, I speak in Spanish, is a
Soy Laura, soy parte del Departamento de Salud Mental.
My name is Laura, and I'm part of the Department of DMH,
Soy promotora comunitaria.
and I work in the community.
Si mi pregunta es, ¿qué está haciendo el departamento para los padres que tienen hijos menores de edad para encontrar un psiquiatra?
What is the department doing to help find psychiatrists for minors that need assistance, for those parents that are looking for psychiatrists and mental health?
Los centros son muy limitados para ellos.
The centers are very limited for them,
That, for minors?
for minors.
Yeah. Yeah, that's, I mean, we have multiple clinics, yeah. Go.
She needs to repeat the question
So
because
she's
Okay.
wanting to, she works in the community for the Department of Mental Health, and she's wanting to know what they're doing for those parents that need help, psychiatric help for minors.
Yeah, it's a good question. Most of the places where we see minors in Department of Mental Health, the title of the clinic is family. And I think, are we talking about support for family, mothers and fathers, or are we talking about for the treatment for the minors themselves?
Para los papás. Because the parent says not too many centers for the teenager or the child.
So for the child, there's not too many centers for the
Yeah,
children.
yeah. We don't have enough, and we don't have enough child psychiatrists. I agree with you. I am vigorously recruiting more child psychiatrists, and I think, in my mind, the age of having pure child centers or pure adult centers, that's not supportive of necessarily the family unit. And we're moving towards support of family treatment, not just minor treatment. And I think for minors especially, family treatment is really critical. And I don't mean just treating with medications everybody. I mean that everybody really needs to be part of the treatment plan and understand what's going on. And so I think, and there are a lot of families that really do better when the treatment is the family-wide. And so my goal is, and I've talked to a couple psychiatrists who are invested in this, and especially for the Hispanic community, by the way, invested in developing real family treatment centers that support everybody in the family, because there's a great part of our population that does better with that kind of treatment. But as far as the treatment for the minors, I agree, we don't have enough. We don't have enough at all levels of care for minors. I'll tell you, to be frank, just yesterday, I was dealing with the LEC-USC psychiatric or pediatric emergency room. They had 5 minors who they couldn't get beds for 2-3 days, and it's really a tragic shame. And the goal is to really right-size our system so that we have enough psychiatrists to see minors, and we have enough resources out there in the community, including subacute and inpatient centers for minors. It's a big problem. Minors are adults of the future. We'd rather stop the problem at the beginning than wait for them to fester as adults. But I just got done. I'm really recruiting a lot of child psychiatrists, and I've told every single one of them, you come to DMH, you can, if there's no child position available, you can be in an adult clinic and do work for children and adolescents, to whatever percentage you want. And that's not lip service. I can give you the names of the people I just talked to. This was just on Thursday, so I'm hoping I have a lot of interest with that. But we need to be real flexible with the services that we have. It's harder to build new clinics than to reconfigure old clinics. And so my goal is to reconfigure the resources and provide enough care in the community that we can move people out of the hospitals and find alternatives in the community instead of having to hospitalize everybody. And that way we'll have a relative increase in the number of beds, and with more child psychiatrists in the adult clinics, we'll be able to treat kids there too. So it is a workable situation. We have a long way to go. I promise you we're going in that direction. That's one of my goals. I'm glad all of you are bringing up things that are
Thank you.
Thank you. Okay.
Thank you.
And I have another one.
This has been amazing. Thank you so much. I can't tell you how informed, how much, I'm sure everyone here is stoked that we get some real answers. My question has to do with LPS conservatorship, and it is a trick bag using hospitals or being forced to have a client or a loved one go to a hospital, get conserved by a doctor who generally doesn't want to keep that consumer there at the hospital long enough to get an appointment with the public guardian and the court. So we ran into something with my older sister where a doctor did say, okay, yes, yes, definitely, I will do the petition. We waited. It was at a private hospital. I'm smiling because I've had many experiences with private hospitals that have not been beneficial to my sister. She has slipped through the cracks. That doctor said he'd show up. He did not. She was sent to a locked nursing facility from which she became a homeless person, escaped, ended up missing, and on and on and on. So I'm wondering, she's not a danger to herself or others. She is gravely disabled. She cannot function on her own. However, I can't understand why the policies of Department of Mental Health or the courts make it impossible. Now, I've been her LPS before. It wasn't this difficult. So if you could give me something, because I don't know what to say to my sister or other family members that have struggled for these last several years.
Yeah, it's a big problem. I'm surprised it took this long for a question about this to come up. Actually, I thought most of the questions would be about this, but even though it's about medications, it's a big problem.
Yeah.
When you mention these things, I heard people in the audience snickering because they're all so used to this horrible process that we have. And I think you pointed out correctly that it's an interdepartment problem. It's not just DMH. There are so many blocks in the courts to getting good care as well too. And sometimes it just depends on which judge shows up for the day too. But there are some things that we're working on. And I'm a realist, so I don't pull punches, and I just don't think that all of a sudden the system's going to improve magically. I look at things in a realistic perspective, and these hospitals, all hospitals, including the county hospitals, look at the bottom dollar, look at the chances for success, look at how many patients are being housed inappropriately in acute care centers for months and months and months, waiting a trial that may not even find in their favor and conserve someone. And then there's the patients getting off conservatorship. And then we have to go through the whole process again. So the legal system is really not supportive of good patient care. I agree with you. Don't know how I'm going to tackle that. But one of the problems is, and I think these hospitals have a valid argument, we're providing this care for free, basically, because we're not getting paid by insurance companies, we're not getting paid by DMH, we're getting low rates, and these patients are filling up, and we can't treat the ones who are urgently in need of care, right? That's a problem. And they have a beef, they really do. So we can't just say you have to do it because it's the right thing. I think we have to respect their needs as well, too. Money is a great equalizer, right? That money is a way that we can fill our clinics in the outskirts where no one wants to work. Money is a way that we can make hospitals very happy about caring for these patients and going through the long process. What we're exploring now, we've already done it on some test cases. We pay hospitals in order to support them. We pay the top dollar figure because we know that otherwise they're going to be, the patients are going to be left out there in the cold. So even though they don't get paid, we supplement that and pay them what they would get for even the urgent care patients. But that's not the full solution. I think that's going to be one of our solutions, but that's not going to solve the problem with all of these patients who are pretty much medically stable and just awaiting placement for months, if not years. We have one patient who's been waiting placement for 2 years, and it's shocking. And one of the ways that we need to do that is we need to move patients through the system. And really what we don't have is enough systems in the community that provide more intensive care in the outpatient setting.
The enriched services.
There is no law that I've been able to find that says patients have to wait in hospitals for months before they get a hearing. We are exploring, and I'm pushing very strongly for this with Public Guardian's Office, we're exploring outpatient conservatorships. We're exploring moving patients out of inpatient hospitals to lower levels of care while they await their hearing, and moving them to the community while we await their hearing. So the goal is to pay the right amount of money to these hospitals, move patients out, and smooth flow patients to the level of care they need regardless of whether they're waiting for a conservatorship, and be able to provide that support. FSP is a critical element, and they provide that support. We need to increase the number of FSP we have out there in the community and provide 24/7 partial hospitalization programs. So there are ways to go around this. I really believe DMH is committed to what, like Dr. Shannon always said, just doing the right thing. If that means we pay extra money, because that's what's needed to get the patients care. And that's what we're going to do. We're already starting to do that. I can give you a multitude of examples. We hope it's going to increase, be more pervasive throughout the MH, and this is going to be our new culture. It's going to take a long time to rewrite our contracts. So, but we're talking a period of months to maybe a year, maximum 2, where we'll have these contracts rewritten and we'll be able to provide more services that are needed. Right level of care, and be able to work through the long time waiting for conservatorship hearings.
Okay.
Thank you so much, really.
And we're hoping that our DMH psychiatrists will be the ones that go to the courts, because all these patients will be managed outpatient. That's where we have
The
power.
accountability of psychiatrists who do not follow through. I don't know what job you get to do where you do that, and then you just kind of trip off through the daisies, while people are just going, oh.
Yeah, I've never heard of such a thing.
Exactly. But they are
DMH
working.
is limited because we don't have the power to tell hospitals really what to do.
Private hospitals.
Private hospitals that
Yes.
we work with, that we pay them for
That's right.
handsomely.
Yeah.
But we do have much more power in the outpatient setting, so if we have more of these outpatient conservatorships, our clinicians who know these patients are going to go up to the courts and support. That's easy. We just need to get the outpatient conservatorship process in place. We've been successful in one case so far.
It's the beginning.
Yeah.
Thank you.
Hi, thank you for being here. My name is Sandra. I have a son who's been 20-some years ill. He's bipolar with paranoia and mania and depression, and he's still diagnosed with alcohol and drugs. Every time he goes to these, not every time, but majority of the time he goes to see these doctors, they give him Seroquel. And that seems to be the go-to drug at the county places he's gone to. And it has not really worked for him. It's made him, for a while now, not be able to live a life, that he was living before working and so forth, just sleeping a lot. He hears voices. I'm just curious what other things are there for him, for someone who hears voices, because he did try to commit suicide recently because they gave him Ruskin when he was in one hospital, and along with a few others, drugs different from Seroquel, and he tried to do this at home. And the other part is that this county mental health office that he transferred to, he wasn't being given an appointment for months and months, because I realized you don't have psychiatrists in abundance, and the only way he got to see one a little sooner was to have the video, which you mentioned. And they said, once you do that, you sign a form and you can't change. That's what they told him. Now, I thought when you weren't happy with somebody, you had the right to change doctors. Or get it, but the way they made it sound like you sign your name on here and you're stuck with this doctor. And it's going to be a video from now on. And the problem I have is that they're not sitting in the room with him. And it's even harder, I think, to read a person or I just think it's a step away from being with somebody. That I think is important. Okay. The question is, what kind of medicine is there that might help with, beyond Seroquel, that might help with his depression and his voices?
There's plenty of medications out there. I may not go down the list and name them, but it's just guesswork, because I don't know your son, and I can't really say what is going to work for him. There are many, many other choices other than Seroquel, and if someone is reflexively giving Seroquel that doesn't work, I don't want to speak for the psychiatrist, but to me that doesn't sound reasonable. What you're describing doesn't sound reasonable. And yes, it can change. It can change at the drop of a hat. But this is, and if I'm going to talk about also the telepsych part, There is no obligation to stay with the same psychiatrist. Telepsych can be considered just another modality for communication. You do not sign your life away to telepsych. If that's the case, you contact the clinic supervising psychiatrist and you let us know, because we'll make a change. Listen, what I firmly believe, which I've been mentioning here, if you can change a doctor, then someone in the Department of Mental Health should be allowed to change a doctor as well too.
Can I ask just real?
Yes, ma'am.
Yeah, the staff too needs some training, because there's a staff nurse who meets the patient and she was rude to my son. She looks like a worker who's been there a long time. I think some of the staff members, I can understand how they could become a certain way after a while. I mean, it's not an easy job. And so I'm just wondering what you can do to get some of that changed, where it's a little bit more pleasant for patients.
Yeah, if I were to deny that something like that is happening, I'd be lying to you. I believe that's happening out there in our clinics as well too. There's a culture over a long course of time that's developed in certain clinics. That doesn't mean it's immutable. My goal, Dr. Partita's goal, our chief of social work, our chief of nursing, our chief pharmacist, our peer chief, all of us really believe that the culture needs to change towards recovery, and that kind of behavior that you're describing does nothing for recovery. It does the exact opposite. So we agree it needs to be changed. How are we going to do that? We go out to the clinics and we work with the clinics personally in order to get that changed. It will be a slow process. I don't believe that training alone or looking at something, having one talk with a psychiatrist, a social worker, a nurse, will have that benefit. We need to be there in the trenches with them and help change behavior over the course of time, because some behavior can be ingrained and it takes, as we all know, it's hard to change.
Okay, we have 5 more